Bismillah. ننظر دقيقة بروفيسور إن شاء الله.
إن شاء الله. إن شاء الله. تشوف الكرسة تتحرك في
اوكي كيرس I can see دكتور كيرسر.
هاي عشان when I'm showing things. تمام.
شنو start دكتور؟
على راحتك.
اوكي بسم الله الرحمن الرحيم. Ladies and gentlemen, السلام عليكم ورحمة الله وبركاته. We'd like to welcome you to the fourth continuous CME, which is held by the Oman Family Medicine Society and Dakhlya Primary Healthcare Committee, in which we are looking and discussing some of the common primary healthcare topics and encounters, which we'd like to update our colleague in the primary healthcare. As usual, we have like expertise from different fields, which who are going to enrich our topics. And as we used to do, we have like Q&As. You can put your questions, so we can put them on answer by the end of the session. And there'll be some polls in which we would like to welcome you to share actively on them. And on the chat area, you can also, put your queries if the voice is not clear or you cannot hear or whatever it is there of the problems of the communication. And today's we are having with us Prof. Salam Kindi. He is our professor in hematology, and he is head of the Department of Hematology. And he is well known on the bone marrow transplant and also in the sickle cell disease management. And he is active member of the Oman Inherited Blood Disorder Association, which is like a community, association, which is working to get people aware about the sickle cell disease and thalassemias. And Dr. Salam had been graduated from the Trinity College, Dublin, Ireland in 1993. He's older than me, I believe, and he completed his general medicine and hematology, oncology training in Dublin, Ireland, and at the Fred Hutch Cancer Center in Seattle, USA. He had done his training on the bone marrow transplant, and he joined us in SQH in 1999. And in 2005, he was appointed as head of the Department of Hematology, as I said, for 10 years. And he held the position of Deputy Director of Sultan Qaboos University. Had a lot of publication and researches, almost more than 100 publications in sickle cell disease, leukemia, etc., autoimmune disorder, and in peer-reviewed journals. And this topic today will be about haemoglobinopathies, and the floor or the ground or the air is yours, Prof. Salam. I think the talk will take how many minutes, Doctor?
I hope it will not take long, but it's a long presentation, so I'll go fast, inshallah.
Great. I think we can go to 50 minutes for talk, then we can go for discussion.
Inshallah, 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 inshallah.
بسم
الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على رسوله الكريم. وسبحان الله يعني اليوم هو يوم كريم أيضا لأنه يذكرنا بنهاية عام هجري وبداية عام جديد آخر. Thank you, Dr. Zahir, for the introduction. I just want to say that I'm not the head of department anymore, and it's Dr. Mohammed Al-Hanini who is the head of department. So just to be fair to my colleagues, and it's an honor to be with you tonight. So I'm going to start with a question. So just to see, to get you all,
shall I show them the question, Doctor?
Yes, please. Shall I read them? Common hemoglobin disorders are classified as structural and quantitative variants, quantitative and enzyme disorders, structural, quantitative variants, and enzymopathy. Or none of the above. Please vote now.
Can you see the? Okay, we'll start. It's already launched, so you can put your answers there. And now you are viewing the poll. Please put your answers there. Okay, you can put the answers on the poll site. Relaunch, I'll relaunch polling. Okay.
Okay. Yeah, okay.
Okay, now you can start putting the answers on the poll. Okay, great. So we'll give you some few seconds.
My slides are not moving. That's the only.
Now, okay, when you finish the poll, Doctor, we'll get out of the poll.
Yeah.
Let me move, inshallah. We got 55 people answered out of the 70 attendees, 76 attendees.
Good.
I think we'll stop now. Doctor.
Yes.
You can see. Can you announce the result, Doctor?
So the poll has disappeared from my queue.
Okay, I'll show it now, Doctor. The results.
Okay. So excellent. So alhamdulillah, most of the people are aware of the answer. We have three categories, and that's absolutely right. We'll close this now. We go to the next slide. Are you going to move it, or I should move?
Yeah, you can move it, Doctor, now. Okay, and now it's okay.
Yes. So as we suggested, there are divided into three major categories. There are structural variants like sickle cell disease, and there's quantitative problems like thalassemia and enzymopathy like G6PD. We will not spend a lot of time on the basic. We'll just, because I want to show you a lot of examples, or where when we are doing counseling for patients, what are the possible encounters that we feel. So adult person has a hemoglobin, mostly hemoglobin A, with a small amount of hemoglobin F and a small amount of hemoglobin A2. We really don't know what A2 does, but it is there. And the reason I'm showing you this, that during intrauterine life, predominant.
We can slow down also.
Yeah, inshallah. The predominant hemoglobin chain is alpha, and as you can see, is also gamma. And that is the predominant hemoglobin in what we call hemoglobin F, that is predominant intrauterine. And you could see that the beta is also rising slowly, and it contributes to about 5 to 10% of the intrauterine hemoglobin. But when the baby is born, alpha continues and slowly beta rise, and then the gamma goes down. And so that's why hemoglobin F decline, and a small amount of delta with alpha to form the hemoglobin A2. But the predominant adult hemoglobin becomes alpha and beta. And this is what we see. So fetal is mostly hemoglobin F and a small amount of normal adult hemoglobin. But then as the baby is born, the predominant hemoglobin becomes hemoglobin A. Now this is actually a normal HPLC in which you see the hemoglobin A is about 94%, hemoglobin A2 here is hemoglobin A2 is 2.7, and then a small amount of hemoglobin F. I'll be using the cursor to show you on the HPLC what are the various hemoglobins that we see. Now, hemoglobin, subhanallah, hemoglobin chains are produced in two different chromosomes. Hemoglobin, the alpha chain is produced in hemoglobin in chromosome 16, and the beta chain and its alike are found in chromosome 11. The way that you remember it for people who are doing exams and so on, the alpha, which is, let us say, the smaller, it's not the smaller in any size, but the alpha start first, is in the higher chromosome, chromosome 16, and beta in the chromosome 11. And hemoglobinopathies are extremely common worldwide. Thalassemia is seen around what we call the thalassemia belt, which is the green here, and it is around the Mediterranean, the Middle East, and Southeast Asia. And sickle cell is predominantly African, so where there is where the sickle is in the sub-Saharan and also in the Middle East and India. And these are the two most important diseases that we will be concentrating on. How common are they? They are very common. 5% of the world population are carrying alpha thalassemia. 500 million people are carrying the gene for sickle cell disease. And we think that is about 1/3 of a million to 400,000 patients are born every year with a hemoglobin disorder worldwide. Predominantly, unfortunately, occurring in the low and the middle income countries. This is from Witherell, where he's a world leader in hemoglobinopathy, and we think that sickle, there is about one third of a million are born with sickle cell disease every year, and about 56,000 of thalassemia every year. In Oman, alpha thalassemia is extremely common, about 48%. This is the data that we got from the study that we did at the university, in which we looked at about 8,000 babies. If you want to see the results, you could see this publication, Hemoglobin, in which we looked at about 8,000 cord blood, and 48% of the Omanis carry an alpha thalassemia gene. 10% carry a beta thalassemia gene. The predominant, of course, is S sickle cell gene with about 6%, but also beta thalassemia 2%, and then other sickling disorders in a smaller percentages, D and C and so on. Sickle cell disease is 0.3% prevalence, and beta thalassemia major is 0.08%. We know that beta thalassemia is predominantly in Al-Batina region, whereas sickle cell is in Dakhlya and Sharqiyya. And then in Dhofar, there is no sickle cell, but there is a special thalassemia called hemoglobin Dhofar. And then there is also another special hemoglobin called S. Oman, found in Batina, and also found in Dakhlya. There is one or two families in Bahla, in which they see S. Oman too. I'll come to S. Oman in a minute. Now, alpha thalassemia, a lot of people get confused about it. One of the reasons for that is that alpha thalassemia has the inheritance is of 4 genes. So if one gene is missing, it's called a silent carrier. And usually these patients are absolutely asymptomatic. They don't have. and a slightly lower MCV and MCH. If they lose one alpha 2 and one alpha 1 from the same side, this is called the Asian alpha thalassemia type, and it's called it's a cis deletion. And this mutation is mostly seen in Southeast Asia. We in Oman see what we call the African deletional type, in which one of alpha 2 from one side and one alpha 2 from the other side are deleted. And so we don't really see a hemoglobin H or hemoglobin BARTs at all, or nearly at all. Then if you have three gene deleted, this is called hemoglobin H. And if you have 4 gene deletion, of course, you know that alpha is required for the intrauterine life. And so this is called hemoglobin BART. And these patients have tetramers of gamma, and they are actually they die in intrauterine or just after birth. And we don't see these. In fact, in the last 20 years since I've been here, I've not seen a hemoglobin hydrops fetalis before. How do we screen it? We do an CBC and HBLC. And if you are thinking, and we do a gene scan, if you are thinking of deletional, then you do a multiplex gap BCR, and you may be seeing some of these reports coming from the Royal Hospital showing you the gap BCR result. If you are dealing with the non-deletional, then it's a little bit more complicated. Fortunately, the non-deletional are less common in Oman. So how does the gene scan or alpha gene scan appears? This is the control, and this is an alpha 1 and alpha 2, and they are of equal size, and this is normal, with 2 alphas and 2 alpha 2 and 2 alpha 1. If one alpha 2 is missing, you could see a small peak of alpha 2 and a normal alpha 1. If you have 2 alpha 2 are missing, then you don't see any peak of alpha 2 and only 1 peak of alpha 1. If you have 1 alpha 2 and 1 alpha 1 missing, you see a shorter peaks of both alpha 1 and alpha 2. And this we don't see a lot in Oman, and we see more of this mutation here, where we are missing alpha 2 from one side and alpha 2 from the other. You could see triplication also, where alpha 2 could be 3 instead of 2, and this is a raised peak. How do you see it in adult, particularly if you have a hemoglobin H in HBLC? You see a peak in the fast moving region, and also the A2 will be extremely low. And this is a patient with hemoglobin H, in which you see this peak in the fast moving region and an A2 of about 1.6, which is very low. And you do an H prep, and you could see the H inclusions are precipitated in this screen. I told you that the most common are the deletional alpha plus 3.7 or 4.2, and you are going to see in these reports that comes to you from the Royal Hospital. As I mentioned, you see these sort of reports. These are all deletional, and this is what we see commonly in Oman. And you could see also the Mediterranean alpha note deletion. The non-deletional are less common, and they are more severe, like an alpha T Saudi, which is reported, as the name indicates, from Saudi Arabia for the first time. And these are associated with a hemoglobin H. This is, I showed you already how HBLC appear. These patients will have a low MCV and a low MCH and a high RBC. And interestingly, if the patient is having a hemoglobin S, you could see that the MCV is 57, the MCH is low, and the patient is anemic, and they have a high red cells, and the S, in fact, is 18% only. So this patient has usually patients who have alpha thalassemia have also a reduced hemoglobin S level. I'll give you those numbers a little bit later. And when we did the analysis, we find that he has a combination of Mediterranean and 3.7 deletion hemoglobin H. Hemoglobin H and hemoglobin parts are very common in the Southeast Asia, and luckily we have inherited the African mutation rather than the Asian. And you could see a spectrum of between asymptomatic, where there's one gene deleted, to an intermediate or thalassemia major, or sometimes even hydrobes. As I told you, we have not seen hydrobes in in Oman. Hemoglobin H is variable. If it was a deletional, it tends to be milder. If it was a non-deletional or deletional and non-deletional, it tends to be more severe. And these patients will have a hemoglobin of about 9, and sometimes splenomegaly. And if they are, if they get problems during pregnancy in particular. Beta thalassemia is, on the other hand, is also important in Oman. It's divided into 3 groups: major, intermediate, and trait. The trait is where a patient is a carrier and usually have a hypochromic microcytic with high RBC and a low MCV and a low MCH. And the classical feature is a high A2, hemoglobin A2. And this is how do we make the diagnosis. You could also have an intermediate where, or you have a major where these patients will require transfusion from the age of 6 months onward, and you have an intermediate where this patient will have a hemoglobin above 7, usually up to 10 grams, and they may not require blood transfusion. Thalassemia mutation have come from various places, from the Indo-Pak area, from Iran area, from Iraq area, and from India, and so on. And these reflected also the migration that we see for the Omanis have moved along in various parts of the world. This is a classical where you see the HbA1c, a hemoglobin A2, a hemoglobin A of 93%, hemoglobin A2 of 4.7, and a small amount of hemoglobin F. And this patient is classical, is a carrier for beta thalassemia trait. And when you look at the peripheral smear, you could see a number of target cells. This is the only thing that you see in thalassemia minor. The mutation that we see in Oman, I don't want to bore you a lot. Intervening segment is the commonest, codon 44, and then hemoglobin Dhafar. These are the 3 most common thalassemic mutations that we see in Oman. And this is a patient who has, at birth, who has a normal good amount of A and a hemoglobin F, and this patient is normal. However, this patient has hemoglobin F of 98% and a hemoglobin A2 and no A at all. So this patient has a thalassemia major with a hemoglobin of 6. And similarly, at 1 year, a patient has a small amount of A, but predominantly F and a high hemoglobin A2. So this patient has a thalassemia major. What are the differentiating features between thalassemia major and thalassemia intermediate? Is the requirement, the major requirement for transfusion. Although we are learning more about thalassemia intermediate now, and with the splenomegaly and a lot of bony changes, and also leg ulcers and so on. And these patients also are prone to silent brain infarction. What about hemoglobin Dhafar? Hemoglobin Dhafar is an interesting, a doubly substituted variant. So you have a codon 29 reported for thalassemia from Lebanon, with a codon 58 reported in sickle cell mutation from Africa. And it accounts for about 6.5 of all thalassemia in Oman. And these patients will have a hemoglobin variable between 7, from 5 to 10 when you have a hemoglobin Dhafar homozygous, and their hemoglobin dhufar will be about up to 40%, between 26 and 59%. And if you the rest is a hemoglobin F and these patients, many of these patients will require transfusion and bone marrow transplant. If you have a carrier for hemoglobin dhufar, the hemoglobin is better, with a hemoglobin mean of about 12% and a hemoglobin dhufar level of 13%, and a hemoglobin, the rest is a small amount of hemoglobin A, and the rest is, of course, is hemoglobin A. And this is a patient where you could see the hemoglobin dhufar is running in the D position, and this is a patient with a hemoglobin dhufar, 14% D position. The last explanatory comment I want to make is about sickle cell. And sickle cell, as you know, is also very common and important disease in Oman. Sickling, where you could, this is a normal test where you could see through the tube, but you can't see through the tube in somebody who has S level. Unfortunately, sickling only determine if the S is present. So please do not rely on it completely. It will only tell you if the S is present, doesn't tell you whether it's sickle cell trait or sickle cell disease, number one. And I want to emphasize that you cannot do premarital screening only by doing sickling test. You have to do HBLC as well to exclude beta thalassemia.
False negative, Prof?
Yes, of course, false negative can occur, particularly if the S level is low. The company check that if the S level is below 10%, it will not be picked by sickling test. But in fact, we have been able to pick an S as low as 3% with sickling test, if it is well prepared. Now, I want to tell you that if the S is above 40%, if the S is below 40%, then this patient has sickle cell trait. If the S is above 65%, then the patient has sickle cell disease. Now, I want you to remember this because then I will come back to some of those points. So this is a patient who has a hemoglobin I don't know why I brought this. This is a normal child at birth. And then this is hemoglobin A2. So you could see the A2 here of about 4.7% and a hemoglobin A. So you have a hemoglobin A2 and a hemoglobin A, and this patient has a beta thalassemia trait. Now, here you could see that there is hemoglobin A and a hemoglobin S and a hemoglobin A2. And so the patient has an S of 29% and the rest is hemoglobin A. So this is a classical sickle cell trait. Now I want to mention, I'll go to the next slide, then I'll mention the point that I wanted to mention. So here, the S level is 34% and the A is 56%. And this patient has also sickle cell trait. Now, if the S is above 30%, then the patient usually have no alpha thalassemia. If the S level is below 30%, then usually the patient is having alpha thalassemia. So alpha thalassemia reduces the amount of S. Yes, so we have gone through this. Now, this is a case that I want to, I'll take a question from you. So a hemoglobin of 9.4 with RBC of 4 and MCV of 65 and a little bit of high reticulocyte, and his hemoglobin F is 12%, his hemoglobin A is 5.4, and his hemoglobin A2 is 6.5, and hemoglobin S is 74%. So the predominant hemoglobin in the HBLC is S, and then there is a reasonably good amount of hemoglobin F. What do you think? What is the diagnosis of this patient? And you will tell me why. So we'll go to the next question, please, Dr. Yasser. Dr. Zahir.
Okay. We are showing the vote.
We can maybe see the results because we will, I'm sure the people are.
We got already 66% voted. Okay.
Very good.
Okay. Shall we continue or just we'll show the result, Prof?
Show the results now so that then I can discuss.
Okay.
I want to see how people fared. Absolutely. So 63% think that they are sickle cell beta thalassemia. Thank you for that. I'll tell you, some people think that this is sickle cell anemia, but I'll tell you. So the reason we think that this is, first of all, there are a number of hints. First of all, the A2 is quite high. When the A2 in the presence of S is above 5.5, according to the various data that we have from SQ, then the patient is probably have alpha sickle beta thalassemia. So this patient has an A2 of 6.5. Don't worry about the hemoglobin F. Many of these patients actually have a good hemoglobin F. And that's one point. The other point, this patient has also A, hemoglobin A, and so he's producing his own A. So probably he's a sickle beta plus. And you could see that the MCV is 65. The MCV in sickle cell disease is usually about 74, 75, up to 78. And so this is a low MCV for a patient with a sickle cell anemia only. Can I move?
Yeah, please. Can click.
Yes, yes. So now I give you some more. So this is a patient with an S of 84% and an A2 of 6.1, and you could see a small amount of hemoglobin F. And this is a patient who has a very high a good peak of S and an A2, and this is a sickle beta thalassemia. Similarly, this patient here has a good A2 and S, and also a small amount of F, and there is also some A present, and this is a patient with sickle beta plus as well. Now, this is a young lady who was referred to me with a hemoglobin of 12 and an MCV of 67 with an RDW of 7.8 and an S of 64% and an A of 26% and an A2 of 5. So what's her diagnosis? Can we take the next question, Dr. Zahir?
Yeah.
طيب.
Already 70-80 answers.
Yes. تفضل.
Okay. And share results.
Yes. So
it's like election, Doctor, here.
Yes. So people have. You are right for the people who have. I agree with the most people selected these three, and mostly sickle with iron. In fact, she had iron deficiency, and she had sickle beta. So, and interesting that this A here, her A is actually her own A. and she did not receive transfusion, so she's a sickle beta plus, and the patient actually caused problem where she consulted one of the hospitals in Muscat, and she was referred to me before marriage. So she has a classical sickle beta plus, and we treat her like that. So she has a sickle cell disease. We go to the next. Yes. Now, here, here is, we have a patient with a hemoglobin S of 63. So I want, sorry, I want you to think that sickle S of 63%. I told you sickle cell disease is above 65%, but here the patient is having 63%, but they have a very high hemoglobin F, so they probably inherited a persistent fetal hereditary persistent hemoglobin F or other gene modifying hemoglobin F, and that's why they have a hemoglobin F. And these patients usually are asymptomatic. They don't have crisis with sickle cell disease. Now we are going a little bit into variation. So you could see that there is an S, and then there is also another peak. It's a D, and this patient has an S and a D. It's called SD. I want to mention 2 points. S and D usually are of equal quantity. So here, hemoglobin D is 45, hemoglobin S is 33, and hemoglobin F is 13%. And usually, if the F is high, the percentage of S goes down, not the percentage of D. I don't know, unfortunately, with SD, the patient have a lot of symptoms, even if the hemoglobin F is high. I don't think, in my opinion, that hemoglobin F is protective in SD. This is a patient who has a very high A2, 34%. So we know that if the A2 is above 8%, and that is not A2. It must be another hemoglobin migrating in the same column as A2, and this patient has an S of 50% and an A2 of 34%, so this patient has an SE disease. And this is a sickle disease, usually very mild, and we have a family, we have a large family in Nizwa, and they tend to be relatively asymptomatic. So I have a question, I don't know, question 4. Yeah, maybe you can give us a question 4, Dr. Zahir, la samaht.
Okay.
So what are the causes of raised hemoglobin A2? Please answer. Shall we?
Okay.
What do you think?
Now we're 65%. Let's reach 70%. We'll stop.
Inshallah.
Okay, just soon. Okay, here we are. I think these are the results, Victor.
Yes, so of course, A2 is elevated in beta thalassemia trait, but also it's elevated in sickle cell trait. The sum of S migrate in the A2, and thyrotoxicosis, I don't know exactly why. And sickle cell disease, A2 will be invariably elevated. And so probably the correct answer is all of the above. Thank you. I will show you now some examples of where the A2 is elevated. I'm trying to move.
You can use the down and up.
Ah, yes, now. So this is a patient who has an A2 of 96%. I told you that 96%, 8% and above, it must be not A2. And so this patient has an hemoglobin E disease, and you could see the high percentage of A2. This is another interesting combination in which you have an S of about 47% and a C of about 44%. And this is an SC disease. Again, it's not very common in Oman, but we see a number of families in Sharqiyya. I want to highlight for you only that SC and C and the S in SC are almost equal, and that is usually what we see. And as I said, usually they are relatively asymptomatic. They face three problems: one in pregnancy, second in eye complication, and third skeletal complication, back and so on. This is an interesting, I missed to make the table, but this is an A and another hemoglobin running in the C position. This is an S Oman, and I'll show you more details in a minute. I don't know why that slide came. So I want to give you a case in which the father is a straightforward sickle cell trait, and the mother is a straightforward beta thalassemia. But the S in the child is 55, and there is a considerable amount of A and an A2 elevated. So the patient has see again here, the patient may not be fulfilling what I told you earlier, that the S should be above 65%, but this patient clearly has a second beta thalassemia with probably this mutation here in the mother is a mild mutation like a -71, and the patient has inherited an S from the father and a thalassemia from the mother. Similarly, this is again a patient who has yes, this is an interesting case in which the A is 44% and the S is 44% and an A2 of 4.7. This is actually, again, another large family from Nizwa. This patient, the proband, if you want, was working in the Ministry of Health for about 30 years in Nizwa Hospital. And he was going to the accident and emergency with chest pain, and every time he gets an ECG and a troponin done. He's already above 70 of age. And we investigated, and then my colleague, Dr. Baha, from pediatrics, referred a number of cases to me. This is a hemoglobin Ladizeradi with, and the Ladizeradi is passing through the A, and the S is here. So the Ladizeradi is in the position of the A. And these patients have what we call hemoglobin Ladizeradi S, and they are usually relatively asymptomatic. Now, this is the fourth case in which the mother is a sickle cell disease with an A2 of 7.9, and the father is an A2 of 6.2. And the boy, again, got an S of 57% and a large amount of A and a large amount of F. And so these are variation within sickle beta thalassemia. Now, we have, I think, the last question before we end. So what are the causes of low A2? And low A2 Please vote. Okay, maybe we take the answers.
Yeah.
Yes, so I agree completely that all of the above. Actually, sideroblastic anemia is also known to reduce hemoglobin hemoglobin A2. Of course, delta is one of our problems. Also, it's known to cause, and I told you already, iron deficiency and alpha thalassemia are also known. I'll give you a good example. So this is a patient. She was so she was a staff at our university, and she came in to see me with a hemoglobin of 9 and an MCV of 68 and an RDW of 30. That was in April 2014. So we gave her, you could see that this is probably an iron deficiency. And then we gave her therapy. And her hemoglobin went up to 12, and the MCV is 81, and her RDW now has normalized. And you could see that her A2 was 2.2 at the time when she came in 2014, and 2.7 at the time in 2016. The reason I'm highlighting this for you is that you could see that she raised by 0.5. Now, you may say that is not significant, but in fact, that is very important. So if you have somebody who has come to you with an A2 of 3.1 and you did not look meticulously, they may be hiding something. And if they rise, if the A2 can actually rise by 0.5, then it will come to 3.6, and that make her a beta thalassemia. But this patient is actually having a normal A2. This is a patient that had a hemoglobin of 9 and an MCV of 54 and an hemoglobin A of 96 and an A2 of 1.6. You could see that there is a peak in the fast moving region, and this patient has an alpha thalassemia as well, and that's why there is actually this patient had a hemoglobin H, and so that is why the A2 is very low in this case. Now, this is why this is an interesting discussion that I had with Dr. Muhammad last weekend. He had a young lady with a hemoglobin of 12 and an MCV of 77 and an RDW of 54 and a ferritin of 32. Her A2 was 3.4 and her A was 93.6. Dr. Muhammad from Nizwa. And actually, in fairness, this is what prompted them to look a little bit more carefully. I usually, when I get an A2 of 3.2, 3.3, I always carefully examine the case to see is the patient hiding a beta thalassemia mutation. And she has an A2 of 3.4, and she's a female. Of course, her iron is not bad. It's a borderline. So he actually sent her to the Royal, to the National Genetic Center, and she's heterozygote for the -71 thalassemia mutation. And she also has an alpha thalassemia 3.7 mutation. And this patient cannot get married to a sickle cell trait. Please just keep this in mind when you have one of those mild thalassemia mutation. They should not, or marry to a beta thalassemia trait. They should marry to somebody who is normal. This is a patient who has an S, I think about 30%, and A, so this is a sickle cell trait, straightforward. And we want to talk about S. Oman for 3 slides or 4 slides. So S. Oman is a specifically for a private mutation. So we have in Oman, we have 2 private mutations, one for hemoglobin dhafar and one S. Oman. And S. Oman, interesting, that has 2 mutations in the same side of the beta chain. So as well as the classical B6 glutamic acid to valine, which we see usually in sickle cell disease, it has another mutation of in the beta chain of 121 glutamic acid to lysine, and which is identical to the Arab mutation. And these patients, although we only see S. Oman trait, but these patients have symptoms. The S. Oman runs in the C position, in fact, a little bit farther than the C position. And in this case, the S. Oman level is about 21%. The higher the S. Oman, the more symptoms. And the S. Oman can vary from 11% to about 22, 23%. The people who have an S. Oman of 16%, 15% and above usually have a lot of symptoms like sickle cell disease. And we have patient who has stroke and has splenic sequestration and has acute chest syndrome, and her S level, Oman level, is about 21%, 22%. This is what I told you already, 2 mutation, codon 6 and codon 121. Now, interesting, we are starting to see combination also. So this is an interesting boy, has a high hemoglobin F, he's only very small child, and has an S. Oman of 6%, but also has an S of 22%. So this is an S. Oman S, and these patients actually require, they become like thalassemia and require blood transfusion. This is another interesting case in which the patient has an S. Oman of 20%. You can see S. Oman here, but has a high hemoglobin A2, 6.7, and has a high hemoglobin F, 20%. In fact, that hemoglobin F has gone down since, but this patient has a sickle S. Oman beta thalassemia, so has S. Oman beta. So now we saw S. Oman S, and now we've seen S. Oman beta. And this is a patient who also get a crisis. So what are the factors to be watched? This is, I think, my last slide. You have to take a family history. You have to look at all the data. In fact, we had one patient from Dr. Zahir about 10 days or 2 weeks ago, and that is what prompted this lecture, in which I find that the patient, one couple, the lady has sickle cell trait, which is straightforward, and the boy has an A2 of 1.5. Now the problem that I wanted the CBC, the father sent me the CBC, but only the hemoglobin is 14. I am happy enough, but I did not see the MCV. I wanted to make sure that there is no hemoglobin H in this particular patient. In fact, as it turned that he had a normal level of A2, but done at a different private lab. And this is another reason I think you have to keep in mind the reference ranges, what people are using. And so we suggested that they should be able to marry. You have to look at all the data, look at the MCV, look at the red cells, look at the hemoglobin, and take a meticulous look, particularly for a borderline A2. I'm emphasizing the A2 because that's where people are missing the beta thalassemia. And then sickle cell test is not enough on its own. It has to be done with HbA1c. And the A2, hemoglobin A2 is very important. I think this is my last slide, Dr. Zahir. And thank you for listening. I know I rushed, but I think we managed okay.
Thank you, Prof. Salam, and for the talk, and which is like a needy talk to the day-to-day practice. And we'll go to the question, if you don't mind, Prof.
Yes, please.
Okay, we'll...
questions.
The questions, Dr. Khalid Atauna, or Ataw, okay, I think, he's asking what is the role of pre-marriage tests to reduce the incidence of hemoglobinopathies in Oman? And what?
So we wanted actually to have everybody tested, and this is what will be proposed to the Minister of Health. And I think we will see this happening soon, inshallah. But, you know, we cannot blame the minister at the moment with all the crises that we are seeing. And this is what we recommend. And we wanted to check, as you suggested, serum ferritin. We have actually a flow chart for the premarital screening, including serum ferritin, and also a CBC and a sickling test, and absolutely correctly. HbA1c, ferritin, sickling, and a CBC.
Dr. Prof, ferritin is like I mean, like acute phase reaction could be, and can also, I mean, it can hide like.
Very good. That's a good question. So actually, I wanted people to use their clinical echoes. If the MCV is low, and if the RBCs are also low, then they have to rule out. So I'll give you the statement about serum ferritin. If serum ferritin is low, it's 100% iron deficiency. If serum ferritin is normal or high, it does not exclude iron deficiency. That is the bottom line. This patient, this doctor is a colleague is asking that I am a beta trait, hemoglobin not coming up more than 9, and I take iron. So you need to look. So yes, beta trait, but it could be that you are moving toward a sort of a beta thalassemia intermedia. That is number one. Number two, you could have a combination of both an alpha and a beta. That is why you are not responding. Number three, unfortunately, many of the times the doctors do not look for other causes of deficiency, particularly B12. And so you need to keep in mind in all of this. And so a peripheral smear is very important to be examined in this particular patient to rule out also is there is no sideroblastic anemia on top of all of these. So these are a number of, so I want to know what is the MCV, what is the RBC, what is the RDW. These are all within the limits of the doctor to look to tell you what exactly is happening. Is it only beta thalassemia trait or is it something else? Is there a specific, Fadal, Doctor?
Yeah, in this question, I mean, sometimes we have like, the same times, I mean, microciting and macrociting
yes.
causes of anemia.
Yes.
Can it hide each other? Because I mean,
of course it can. So when you have a combined deficiency, it will actually bring the MCV down. And I don't know why the Omani people have a reasonably high-ish prevalence of B12. Is it a malabsorption syndrome, or is it or are we yeah, so I don't know. Of course, there are a number of other conditions that contribute to B12 deficiency, particularly hemoglobinopathies, patients with diabetes who are taking metformin, and so on and so forth. So there are a number of reasons, but B12, in fact, folate is not a major problem in Oman because a lot of food products are fortified with folate, like flour, like milk, and so we don't see folate deficiency.
Can we go to the second question?
Yes, is there a specific treatment for sickle cell patients, especially for those having recurrent crisis? So, yes, so lumbar spine infarction. The degenerative changes of sickle in the spine is a trouble for me. Unfortunately, we don't have. A lot of these patients have alpha thalassemia as well as sickle cell disease, and they get a lot of avascular necrosis of the hips as well as lumbar spine abnormality, or even the rest of the spine abnormality, and they get collapse of the vertebral bodies. And unfortunately, we don't have a solution, and we don't really know what stop this manifestation. We don't have a solution for it. I have tried earlier in time to link with the neuroradiologist at Dakhlya to do what we call vertebroplasty, but it has not really been very fruitful, number one. And second, we know that bone marrow transplant is one of the solutions that actually inhibit the progression of these skeletal manifestations.
Great. And the question,
of course, there is one more thing I want to mention to the colleagues who are joining from all over the place. There are 3 new drugs for sickle cell disease. Thank God for this. One is L-glutamine, and L-glutamine is an amino acid pharmacologically prepared, and it has an antioxidant action, and it actually works reasonably well with minimum side effects. We have started using it in a small number of patients, and we will see the outcome. I can't tell you my experience yet. We have another drug that has been recently approved by the FDA last year, November, called Foxilitor. And we have a number of patients on trial on this drug, about 11 patients in Oman. And it raises the hemoglobin. And this is an interesting drug. It interferes with polymerization, and it raises the hemoglobin. And it is useful for patients who have low hemoglobin. And the third drug is crizanlizumab, and crizanlizumab is an anti-adhesion molecule, and it's an antibody, and it's given once a month injection, and it is a very useful drug also. On HBLC, how much percentage of hemoglobin S to differ as sickle cell disease from carrier case? I told, if the S level is above 40%, please check that there is no thalassemia mutation. If the S level above 40%, please check. If the S level below 40%, then the patient is sickle cell trait. Okay, and so if the S level is above 40%, please check to make sure that this is not a thalassemia with sickle cell disease with S.
Yeah, can we get this? I mean, like an algorithm to simplify that for the colleagues. I mean, like how to go on reading, like flow chart. I mean, if so goes. So this is like more like algorithm. And
yes,
can we get artificial intelligence working here also?
Of course. But I will look to see if there is an algorithm, and we will communicate, and maybe you will share it with the colleagues who are attending. Somebody asked, can sickle cell trait get symptoms? Of course, I give a lecture on the complications of sickle cell trait. But we like to tell that these patients are asymptomatic, but they are in fact not completely asymptomatic. So they can have renal impairment and a lot of hematuria in particular. And we know that renal failure is more common in sickle cell trait. And if you look at your patient with renal failure on dialysis, you will see that the percentage of sickle cell trait is higher. Number one. Number two, they have more thromboembolism as well. They can also get splenic sequestration. They can get bribism. And we have published paper on bribism with sickle cell trait. And then there are a number of other less complications. But these complications do occur only in extreme circumstances. So if the patient is playing American football with intensive training, or he is doing he's training for the Marines in America. Then now the Marines and the American Football Association test for sickle cell trait, because you know that African Americans are much higher percentage in American football, and so they or basketball rather, and they had sudden death in these patients. So there are some side effects, but these in general they are asymptomatic. Now, what about the percentage of S? Yes, what probable age for HBSC? The best age for HBLC is at the age of 6 months and above, where you will see the adult hemoglobin. What's the range of S? Between 45 and 65. So I showed you already a number of cases in which the S is above 45, and 53, 50, 55, 60, 62, these patients have sickle cell disease. Sometimes they may have received transfusion, but these patients are certain to have sickle cell disease with mild thalassemia mutation invariably. And is this, sorry?
There's a question upstairs about the cut values between HBS, between trait and disease. Previously, I know it's 40, but Prof. Salam said it is 65. Just to clarify the statement.
Yes, so I told you that the S is above 65 is sickle cell disease. The S below 40% is sickle cell trait. Now, you see I showed you already examples where the S is not 65%, it's 44%, 50%, 53%, 60%. These are all sickle cell disease with mild thalassemia mutations. Treat them like sickle cell disease, please. And treat them in counseling like sickle cell disease. If the S above 40%, please check for beta thalassemia mutation.
Great.
When you consider IV iron, what's treatment of iron? So iron, we are using a lot IV iron nowadays, because if the lady is intolerant to oral iron, then there is no point pushing her to take oral iron. And IV iron is safe, and you can give it safely in the daycare. And when I come to Nizwa also, we have done with Dr. Rifat a number of these patients in Nizwa, and now they are doing it themselves. So I think iron replacement IV is a very useful treatment, and the patient get better and they feel better.
What about anaphylaxis and this issue, Doctor?
Yes, so very rare, Dr. Zahir. What we do with the first dose, we give it while we are there and watch. But the subsequent doses, you can give it in the evening or whatever. But rarely the patient develop a reaction, rare. Maybe once in a little while only. And you slow the infusion and give them prophylaxis, like hydrocortisone and antihistamine. Should we clear sickle cell trait for sport activity? So I don't know, in Oman, I don't think there is anybody who is doing a very intensive training for sport, unless they are going to do mount climbing, or going to climb the Himalaya, or going to climb Kalimangaro, or be driving the F-16. Then these patients should be advised not to be a pilot in a military airplane. But in general, I have seen policemen and army people, even with sickle cell disease training, and they don't have symptoms. I'll just tell you a story that when one of the SC from Nizwa said, "Doctor, it doesn't matter what you will tell me. I want to do the training, and I'll do the training." And he did the training, and he said the army training, and he's SE and thank God he did not have symptoms. But they have to drink a lot of fluid, and particularly in the heat. What are the indications for hydroxyurea? So the indication for hydroxyurea are many. In fact, nowadays, if somebody is willing to take hydroxyurea, I give them hydroxyurea. I offer them hydroxyurea. The people who have high hemoglobin F get higher hemoglobin F. And the people who don't have high hemoglobin F, they may get higher hemoglobin F. So I think there is no harm at all of giving hydroxyurea. Hydroxyurea is safe. We have been using it for the last over nearly 30 years, and there is no complication from hydroxyurea. The only time is if the lady wants to get pregnant, then I stop hydroxyurea, or if the boy is getting married, new wedding, then I stop it for about 3 months, 6 months until he gets children, and then he restart again. Can rare types of hemoglobin get married with beta thalassemia trait? So I recommend not. So for example, if we have an S beta with a -71, who is a very mild disease, he may get an S, the S to be inherited with a beta thalassemia, and he will get a sickle cell disease. So the boy will become sickle cell, the baby will become sickle cell disease. I don't recommend. I recommend anybody who has a beta thalassemia mutation to marry normal, and a person who has an S of any type, an S with beta, he should marry only normal person from the beta chain point of view.
Okay, there's another question about, Prof. Is it applicable to start iron therapy in low hemoglobin, or has to wait for HBLC in primary health care?
Yeah, so actually this month I got one lady who getting married, her A2 is not so convincing, 3.1. So I started her on oral iron, and I did not, and I'm going to repeat her iron after about 6 weeks, her HBLC after about 6 weeks, because she is marrying to a boy who is sickle cell trait, and I don't want to take chances. But I think giving them iron, look, I'll tell you my own experience. When I went to Europe, they saw my MCV to be low, so they gave me iron. They gave me iron before doing the HBLC. And I think there is no harm doing that for some times, not to go for months and months, but maybe for 3 months to 6 months, and then repeat and do the HBLC.
And about the question about stem cell and beta thal therapy?
Yeah.
The role of stem cell.
Stem cell, beta thalassemia.
Yeah.
So,
of course, we'll get like one session for sickle cell disease later on. I think it looks like another topics to be discussed later on. But then there's questions of the for a quick answer.
Inshallah. So both beta thalassemia major and also sickle cell disease are cured by bone marrow transplant, and we have a very good success with thalassemia. We have over 50 cases of thalassemia and nearly 50 cases of sickle cell disease transplanted at our SQU, and they are doing extremely well. Of course, we have some rejection, and we have also had 1 or 2 deaths, but these are like sickle cell disease patients are also dying without transplant. So I think many of these patients, their life is changed with bone marrow transplant, and I think I support its use when you have a donor who is not sickle cell disease. Somebody is asking about COVID-19 and sickle cell disease or sickle cell trait. There is no problem. Sickle cell disease also and COVID, they behave like a normal population. We have not had really major problem with sickle cell disease with COVID. Some of them needed to be admission, and some of them need to have exchange. We have actually a number of pregnant ladies who had COVID and sickle cell disease, and they needed exchange and needed transfusion. but in general, alhamdulillah, إلى الآن, they have done good. And sickle cell trait, I did not even look for it because you cannot follow every sickle cell trait. Do you recommend patient with beta thal post BMT to marry a lady with hemoglobin D trait? So you see, the bone marrow transplant does not change the gene, and so if they have a beta thalassemia, thalassemia with hemoglobin D, it should be a mild thalassemia. I don't recommend that they should marry because his gene will be there. The transplant only change the production of cells, but the gene will remain. And so I don't recommend that they marry a D. I actually this has come to me at SQ. What about the cause?
Yeah. Please.
What about the cause of thrombocytosis, platelets more than 1 million in sickle cell? In general, thrombocytosis is associated with the absence of spleen, and we see a lot of these, and particularly it can rise to 800, 700, and these patients will require aspirin. I give aspirin to all of these patients who have high platelets. If they are a candidate for hydroxyurea, it's also good to use hydroxyurea for them. But in general, you will find that their platelets, if their spleen is gone, and that's why they have high platelets. Now, if you are worried about myeloproliferative, I still have to see a case, and we have about nearly 4,000 patients with sickle cell in SQU. I have not seen a myeloproliferative with sickle, but it's an interesting combination. Maybe we should be looking for it more carefully. Where do you want me to go? Some reference points for the normal A2 up to 4.5. Yes, so in Oman, 3.5, please. And if you look, yes, there are, so depending on what mutations we have and what background we have, and that saves us from missing some of these cases with beta thalassemia trait. And I think Iran take an A2 of 3.8, and that's maybe applicable to what they have there. So that's okay. But according to the WHO, I think now 3.5 and above.
There was a question about the new drugs for the sickle cell.
Yes.
Ability as MOH or SQH, which of them is available?
Okay, I don't want to tell the secret, so.
We'll skip it.
Anyway, no, we have L-glutamine at the university, but we have problems with the supply because, you know, at the moment, الآن عندنا قحط نسأل الله السلامة إن القحط يتحسن يعني.
حتكون أمطار إن شاء الله.
أمطار إن شاء الله، أمطار مالية. وبالنسبة للفوكسيليتور is available for trials. Only the trial patients that are getting it now. And crizanlizumab hopefully will come also for trial soon. So if there are people who think that there is a candidate for crizanlizumab, they can communicate with me. We will be starting a trial maybe soon, inshallah.
About the question of doing HBLC routine in pregnant ladies with sickle cell.
I think that is a very important, for sickle cell.
Here it is like the question, is it necessary to do routine HBLC for pregnant patients with sickle cell trait? I mean, do they mean that they need to redo, or?
Yeah, how many? So I wanted to answer this question first, and then I'll come. How can we give, how about S of more than 65% and A2 more than 5? Can we still differentiate between sickle anemia and sickle cell disease beta, since both can have a hemoglobin higher than normal? You're right, but what we have adopted at the university is if the hemoglobin I use my sense. So the hemoglobin A2 of 5.5 and above in the presence of hemoglobin S is very suggestive of beta thalassemia, sickle beta, number one. Number two, almost always you will find the MCV to be below 70. If the MCV below 70, then you know that this is sickle beta. So these are the two that I use for judging. What was the question you were asking, finding?
About the question repeated twice. Is it necessary or is it routine to do HPLC during antenatal care for pregnant patients with sickle cell trait? I mean, does it change?
No, if the patient is already known to be sickle cell trait, then don't repeat it. If you are not comfortable, that's a different issue. But if the S is below 40%, please don't repeat it. No need, no need. We save the country some money. So HBLC, if it's done already and the patient has sickle cell trait, then there is no need to repeat. And these patients usually don't have symptoms and you treat them like normal, but you have to be careful with their level of hydration and so on, and they may get more UTI during pregnancy. So these are some of the things that you look for.
About the question, how can, I mean, is it possible to give counseling patient with delta thalassemia? And
yeah, so delta is a big issue. It doesn't cause problems, so I don't want you to be worried about. We have published a paper on delta. What I did with that delta paper is that we looked at all the patients who have a low hemoglobin A2 less than 2%. If the hemoglobin A2 less than 2%, 1.8, 1.9, then we did delta, and we find a number of these patients with delta. And in fact, we have found a de novo mutation in Omani only. We have published this paper. But I don't want you to be worried about delta. It's asymptomatic and it does not, it may lower your A2. Are we missing some beta thalassemia trait? I can't tell you, but I don't think so. Tafadhal.
Okay.
In our clinic, we get 7 out of 10 CBC showing hypochromia and microcytosis. The rate is so high that we are using the same reference range for in SQU. So I agree with Dr. Faisal that first of all, I told you that 50% of the population have alpha thalassemia. So you may have a mild microcytosis in many of these patients, but you have to use your intelligence, let us say. If the hemoglobin is good, above 12, if the RDW is not high, if the RBC is okay, then these are the sort of judgment that I am, maybe one day Dr. Zahir will do a CBC interpretation.
Yeah, I think we are planning already on this.
Yes, so we can do CBC interpretation, and I select some of these CBCs that may be useful in day-to-day practice, inshallah.
Inshallah, great. And a question about, is it normal to get low platelet in pregnancy?
Yeah, so the platelets are lower in during pregnancy, but yeah, so that's one issue. And then there is gestational thrombocytopenia, which occur in pregnancy and it improves with delivery. If the patient has a platelets safe range above 50, above 75, and no symptoms from bleeding, then don't trouble yourself. If the patient is going for cesarean section, then a platelets of above 75 is very safe. We get a lot of questions about this from the gynecology. And so there are a number of, it can be ITB, chronic ITB, it can be other thrombocytopenia in pregnancy like HELP syndrome and so on, but you have to make judgment and make clinical assessment, look at the liver enzymes, look at other causes to judge. That's my comment.
I think the previous question is answered. He asked about I saw many CBC with normal HB with low MCV.
Yes,
That
yes.
is the same answer before. Is it an error from the machine or from our genetics?
No, no, it's from our genetics, and also iron deficiency. I, we look like we have to cover so many things. So iron deficiency is very common in Oman. We did a study at the university, and 48%, about 50%, 52 actually, 52% of the ladies have iron deficiency, miskinat. And 28 of the boys, you will be surprised, have iron deficiency. And of course, some of them have iron deficiency anemia, and some of them have iron deficiency only without anemia. And we have published this paper also if people want to look at it. So low MCV with microcytosis is very common, unfortunately, in Oman. And that is why ladies, for example, are not able to donate blood because their hemoglobin in general are low.
The final question, Prof. There is some finding of the hepcidin suppression by iron loading through daily oral iron supplement. Do you recommend giving ferrous tabs on alternate, not on daily basis?
So the data I am not aware of hepcidin suppression. We know that hepcidin is low, for example, in thalassemia, and the thalassemia major, and this is one of the reasons why these patients actually absorb more iron. I have to look into the whether giving iron replacement on a daily basis versus daily will alter the hepcidin, which means that they will absorb more iron. I have to look at that data, but that is a point. Thank you for asking that question.
Yeah, I think we are reaching 3 minutes to finish our session. We'll go for the sickle. Does sickle cell patient who underwent bone marrow transplant, can it affect their gonadal function?
Yes, of course. This is a very important question. So, for example, let us look at it from a general point of view. When sickle cell patients have a reduced sperm count, even without transplant. Now, I think they have a reduced sperm count, in my opinion, that does not interfere with their fertility generally. And so they are able to conceive children, and the ladies are also able to conceive. But when they receive the conditioning therapy, that impact on sperm count is exacerbated. And so, yes, these patients will have a dysfunctional gonads post-BMT. Now, I want to give you two comparisons, to give you an example. So we use at the university what we call reduced intensity conditioning, and we use the same program for sickle cell and the same program also for BNH, or paroxysmal nocturnal hemoglobinuria. The patient with paroxysmal nocturnal hemoglobinuria, all of them don't lose, or so far the one that we have done, all of them did not lose their fertility. Whereas in sickle cell, becoming hypogonadal is more common. And so it is not to do only with the drug that we use, but also with the primary disease. But in fact, that is an issue that we have to discuss with the patient. But many of our patients, particularly females, are able to conceive, and also the boys are also able to have children.
Yeah, there are some questions are put on the chat areas. Okay, and of course about the sickle cell and drug use, we're going to discuss it in another session, sickle cell disease management. And about the one case, they have a family with beta thal C who can, how could be detected or something? The question is not clear for me. Is it clear for you, Doctor, in the chat?
Is it in the chat? Let me go to the chat. participant. Question and answer. Why the chat is not a...
Okay, I read for them. I read it for you, doctor. And the question here, if you have a sickle cell, I mean, HbS more than 65, another question.
Yes.
If the HbS is above 65 and HbA2 is more than 5, can we still differentiate between sickle cell anemia and sickle cell disease S beta thal, since both can have HbA2 higher than normal?
Yeah, so we answered that question that if the S is above 65 and hemoglobin 5 hemoglobin A2 is above 5, I told you that in the presence of S, A2 is almost always elevated because it migrates in the same column. It's close by. A2 and S are close by. So if the A2 is above 5.5, then you could be certain that this is sickle beta thal. You can judge by looking at a number of things. Number one, the patient may have spleen. Persistent spleen is more suggestive of sickle beta than no spleen. Number one. Number two, they may even have a thalassaemic fascia. Number three, they will have a low MCV. Number four, they may have a higher red cell counts. Number five, they may have a lower platelets. And so these are all hints that will help you differentiate between S beta and SS. But when you are counseling, it doesn't really matter. They are sickle cell disease and they can only marry normal person. It doesn't really matter whether they are SS or S beta.
Yeah. There are pending two questions, and they are out of the topic about iron deficiencies and the religious issue. Shall we keep it for the second session, doctor, or would you like to answer? Finishing the time. I think we'll put it for the second because CBC will cover some of the issue. And it raises the question about, we'll get the rhesus. Could it happen that a baby born negative rhesus in spite of both parents are positive?
Yeah, so you have to look at their phenotype for rhesus. They may have one of those minor. I am not so good in blood transfusions, and so yes, you can have a baby with a rhesus negative if the parents are not rhesus negative.
Yeah. Thank you, Dr. Salam, for the 1.5 hours, which is fruitful and brought us a lot of questions. And here, I think, I mean, we need to get like continuous CMEs. Of course, we have like a different reporting system from Royal Hospital, from other labs, from the SQH, where they report the, the electrophoresis and the S and the in different manners. So I think we need to get like a systematized national one. And the question about the how to go with the like a flow chart and how to go with the results will be like more helping to the primary health care and when to refer or when to get a second opinion from the you as hematologists or other colleagues, when to get a help or before they give advice and when to stop and rethink in such lab results. Thank you, Prof. Salam. I think we are getting some question about CBC. I think we'll get another session. And we may consider iron deficiency, which is more common also topic about screening, evaluation, management, and other issues. Will be another issue there. A lot of people are asking about CBC. And thanks a lot, colleagues, attendees. It was active. More than 110 or 20 participants have been on with us today. And hope you get like some add-on knowledge. I believe it is done. And we'll continue updating you with the more of a lot of hematology, what calls topics. Inshallah, Prof. Salam, thank you for getting us some of your time. We kept you away from your dinner, and inshallah, happy year for all. happy Hijri year inshallah وكل عام وانتم طيبين وإن شاء الله fruitful year. We should be positive and we should think more also positive. Also we have some crises, coronas, etc. But I think we are learning, we are getting more knowledge, we're getting closer to our families, and a lot of things are also positive in this era. So thanks Prof. Salam, and thanks for you all attending. You will get like certificate of attendance through your email inshallah. And we'll send you like updates on the coming CMEs, hopefully. Thanks a lot, Prof. Thanks for the attendees. Any final word or statements, Dr. Salam, for the attendees?
No, I'm so pleased, and mashallah, attendance was excellent and a lot of interactions, and I'm happy that that I've been able to talk to you and talk with the colleagues. And if there are questions, of course, we'll be happy to help. Yeah, inshallah, hopefully we'll meet in another session, so do a slightly different thing.
And we'll announce it about when CBC session will done. We'll announce it through the your emails and through our WhatsApp groups, family medicine, GB groups, Oman Association will do it, and on your emails, and in our Twitter, Oman Family Medicine Society Twitter, you can access it and you'll find the details there. Thanks, Prof, and see you soon, inshallah. And we are closing the session. Hopefully we meet again. Thank you, Prof. Thanks all attendees.
Thank you, Dr. Zahir. Thank you. Thank you.